Next, we're going to discuss another antidepressant drug class, the TCAs. And this stands for tricyclic antidepressants. So unfortunately not an as beautiful name as the others, SNRIs, SSRIs, where you can immediately predict what is a mechanism of action. This is a chemical name that tells you about their chemistry, that there are 3 cycles, but it doesn't help you necessarily to predict what they do. Now, it turns out they act exactly the same as the SNRIs. They also block SERT, the serotonin reuptake, so TCAs, and the NET, TCAs. So actually, they are SNRIs, but they're chemically different, and they have also different features. Some people call them dirty SNRIs, and that's actually a pretty good name, because what they really do is they do the same as the SNRIs, but they have off-target effects. They're not as clean drugs. They block other receptors as well. Which other receptors do they block? They block 3 other receptors. Let's make a little triangle here. The H1, the alpha-1, and the muscarinic. So you can remember that as HAM, H1, alpha, and muscarinic. They do this in addition. And this leads to several adverse effects that we're going to go over. Other adverse effects we already said with these antidepressants, we can also always predict the adverse effect based on which neurotransmitter they increase. These are dirty SNRIs. They increase serotonin and norepinephrine, that's in their name here, and that means increase in serotonin. We know already what that leads to, increase in norepinephrine. And I also want to name one that you should remember. A famous one is amitriptyline. So the amitriptyline is generally a good one for the TCAs. There are more triptylines, amitriptyline, nortriptyline. There are also imipramine, decimipramine. Pramine is also good any. But let's just stick with amitriptyline as a good example for a TCA. Now, if you watch closely, I actually have removed one of the adverse effect that usually norepinephrine leads to. Does anybody remember what that was? Well, I hear somebody saying, here, the blood pressure is missing. And that's true. I erased the increase in blood pressure, the hypertension, because you're not going to see it with amitriptyline and with the other TCAs. Why? Well, you can think about that. You can pharmacologically explain it. They have a lot of off-target effects. And we're going to see here the alpha-1 receptor. Well, if you block the alpha-1 receptor, you get orthostatic hypotension. And, well, if you get hypertension due to norepinephrine increase, well, when the alpha receptor is blocked, you're not going to get hypertension. So therefore, you're not going to see that because of the off-target effect, because we have here dirty SNRIs. And just for your understanding, so orthostatic hypotension, why is that with an alpha-1 blocker? I hope you remember that, well, when you're standing up from a lying position, usually your blood volume goes into the lower extremities, and then there's less blood pumped through the heart. Who's going to pick this up? The baroreceptors in the carotid sinus and the aortic arch are going to pick it up and say fire sympathetic, so that we get norepinephrine release, and then our veins are squeezed and the blood comes back. But now, unfortunately, the alpha-1 receptor is blocked here in these drugs, and therefore there can be no squeezing of the veins, and the blood volume is not going to come back, and you're going to have hypotension. Then other things that you're going to see with these drugs are related to the blocking of the H1 receptor. And I hope you also remember what H1 is going to lead to: weight gain and sedation. And you may now ask, well, we have here agitation, here sedation. The rule of thumb is that the H1 effect is probably going to be the stronger one. However, it's not everything so easy, because when you are thinking about major depression by itself, some patients don't get out of bed, some patients don't get in bed, so they have insomnia. So you start at very different levels, so it's going to be very hard to predict anyway. And here we have opposing effects, but generally, H1 is fairly strong, so you may more be sedated than having here agitation, insomnia. But that's just a general rule. Antimuscarinic, I hope you know some of them: dry mouth, blurred vision, constipation, urinary retention. So the typical antimuscarinic adverse effects. So these are the TCAs, very similar in their mechanism of action, same as the SNRIs, but have definitively more problems, particularly from this off-target effect. Another thing that I also wanted to mention, that they are fairly cardiotoxic, and I'm going to write this with a different color because that's really important. These are cardiotoxic drugs. As another important adverse effect. And why is it? Well, first of all, they increase heart rate via several mechanisms. So we know already here, increased norepinephrine leads to tachycardia, but also antimuscarinic leads to tachycardia. Now, when you have alpha-1 blockade, you're also going to get reflex tachycardia. So a lot of things that's going to happen to your heart rate, increasing your heart rate. That's something you need to think about when you give this to a patient. This may not be good for patients with any underlying cardiovascular diseases. Also, these drugs have a quinidine-like effect. Does anybody remember the drug quinidine? This is an antiarrhythmic which has sodium and potassium blocking properties. Sodium and potassium, that's a potassium K, blocking properties. And you probably know what's going to happen when you block potassium channel. That's something very dangerous. You're going to get a QTc prolongation, and that can lead to torsade. And that's obviously also one reason why they are considered very cardiotoxic. They can be also dangerous in an overdose because of all the effects on the heart. So usually when the dose is too high, you're definitely going to see some ECG abnormalities.